Obesity is increasingly common, affecting 1 in 8 people worldwide and over 40% of adults in the United States. Infertility, many individuals face obesity face unique challenges, especially in IVF, often encountering strict BMI cutoffs at clinics that can deny them care solely on their body size. That there's no doubt causes anxiety and limits access to treatment. This review by Johnson and colleagues explores whether BMI cutoffs in fertility clinics are truly necessary. So, looking at their center, an academic center with no BMI restrictions, they went through careful planning, proper resources, and patient centered counseling. Individuals with higher BMI in that center could achieve treatment. And what they found out was that if you are able to plan properly, including extra doses, the number of eggs retrieved, quality of embryos, and pregnancy rate showed no significant difference if you adapted certain specific protocols. One of the reasons why clinics use a BMI cutoff often is due to surgical anesthetic risks, and certain clinics can plan to change their protocol and try and see whether they can give the best care with higher BMI. These authors call for a broader adoption of flexible protocols so that patients of all treatment sizes can be treated. This research supports a shift away from arbitrary BMI restrictions, and as obesity rates continue to climb, the question asked is does everyone need a better care? Now, why is it that certain clinics or a large majority of clinics have a cutoff, including in the UK, where the cutoff often ranges between BMI 30 to 35, and that is based on almost all clinics. And there are reasons. Many of them are anaesthetic reasons, which is airway management and the risks of not being able to ventilate well, greater risk of oxygen desaturation and respiratory depression during sedation, and obstructive sleep apnea that happens in obesity, requiring far more critical monitoring and a different additional type of monitoring. The medication doses, a higher dose of medications are required. Gastric emptying time is delayed, and use of GLP-1 receptor agonists may in fact further delay gastric emptying, making it more challenging. Often there is difficult IV access, and with any challenges that occur with airway, there is a serious risk to the patient. Surgically, there are longer operative times. There is access challenge, and sometimes the ovaries become inaccessible generally due to high BMI. The risks of infection and bleeding continues, and sometimes it is difficult to diagnose them. Due to this, many clinics will not treat BMI between 30 and 35, and that can vary. And there are probably certain hospitals which have a huge hospital backup for managing complications or trying to offer care that is extremely complicated, and probably should be restricted to those centers that are able to do it. And that is what the paper says. It says we should try our best to try and upgrade treatments and be able to offer treatments to this select group of women with higher BMI, possibly in more well equipped and advanced centers, which are often based in big hospitals.